The Fall Psychiatric Symposium will start shortly. This gives me an opportunity to tell you more about the Mental Health Association of East Tennessee. The MHA was founded in 1948, and since then, we've been fighting the stigma of mental health. We've been assisting clients through our call center. We've been focusing on early childhood mental health conditions by intervening in schools at the earliest onset of symptoms. And we've been providing free mental health screenings to those who are struggling. When people reach out to the Mental Health Association for help, they're often scared, they don't know where to turn for help, and they're afraid of what their family or friends are going to think about them for reaching out for help. When they call the call center, they're going to find a lifesaver at the end of the line. They're going to find a warm, comforting voice and someone who is a great listener. At the call center, we're going to help our clients find the treatment or support that best fits their needs. And then, as I like to say, the magic happens.
When people call here, they're calling for help. They're calling for hope. And that's what I try to provide for them.
Our team keeps building relationships with our callers. They'll call you back and provide ongoing peer support to support you in your recovery. 50% of all people with mental health conditions begin experiencing their very first symptoms by age 14. Earliest symptoms can come in and then disappear, confusing them, their family, or friends. They start to wonder, are their symptoms real? Are they better now? But eventually they experience longer episodes of those symptoms. Sometimes newer symptoms pile on and they become more severe. Young people wait longer than any other age group to seek treatment, with most waiting over a decade. This makes them vulnerable to greater impairment and potential lifelong disability. That is why we created Mental Health 101. Mental Health 101 changes the conversation about mental health, helping our teens recognize signs that they or a loved one needs help and motivates them to speak up and get help. The MHA, helping kids every day. Mental health conditions are a lot like medical conditions in that they have various stages. Stage 1, the earliest stage, symptoms are mild and often will recede. In stage 2, symptoms increase in frequency, duration, and start to interfere with work, school, and life activities. At stages 3 and 4, symptoms drastically worsen, disrupt life activities, and can become life-threatening. If you are overwhelmed, having trouble coping, I urge you and those you care about to take a free, confidential screening. Don't wait until it's a crisis or life-threatening. Find out what it is that troubles you, reach out for help, get help. Screen now.
I want people to know about mental illness, that it is okay. It does not have to be a dirty topic. It doesn't have to be a bad word. It can be something that we talk about openly and honestly. And if we do that, then imagine a place where everyone was free to be who they are. We would absolutely change lives if we could do that.
Mental health has affected me because when I was younger, I had mental health issues and they were undiagnosed. A, because my family didn't have the resources to be able to support me to get the help, and B, because there were not a lot of therapists in the area at that time.
Seek help when you see changes. When an individual experiences and talks about suicide and grief, when you start seeing changes like this, don't wait. Get help for them. There are resources out there. And don't forget to get help for yourself too.
Thanks for watching these important videos about what we do. You can support the Mental Health Association of East Tennessee by going to mhaet.com and click on the Donate tab at the top of your computer screen. Thank you very much for supporting us in this important work to serve our community. Good morning and welcome to the 24th Fall Psychiatric Symposium. My name is Ben Harrington. I'm the CEO of the Mental Health Association of East Tennessee. On behalf of the MHA, our wonderful board of directors and staff, we thank you for joining us today. 24 years ago, we started something we had no idea would grow from a small conference to one of the largest multidisciplinary psychiatric training events in the South, if not the country. Little did we know that COVID would throw us a curve like it did last year. Well, it's continued this year, and let's knock on wood that this is the last time we do virtual Psych Symposium, and we can be live and in person next year. I think everyone's really hoping for that. So the symposium is a resounding success because of the fantastic support of our mental health professionals and addiction professionals throughout the region. So thank you again for being here. And I also need to let you know that obviously we couldn't do this event if we didn't have great accreditation and funding partners too. So let me share those with you. The symposium is accredited by the University of Tennessee Graduate School of Medicine, University of Tennessee College of Nursing, the National Association of Social Workers, the Tennessee chapter, Knox Area Psychological Association, and the Tennessee Department of Mental Health and Substance Abuse Services. Of course, this symposium is successful because of generous sponsors that are happy to sponsor the event, support the event with exhibits, that sort of thing. We have what is called a virtual exhibit hall. It's actually the exact same virtual exhibit hall that the NFL is using. So there's your fun fact to start you off at 8:20 in the morning. Our sponsors include the Tennessee Department of Mental Health and Substance Abuse Services, United Healthcare, Recovery Strategies, Johnson & Johnson, Janssen, and Cornerstone of Recovery, which is merged with Bradford Health. Focus Treatment Centers and Focus Integrative Treatment Centers, Cumberland Heights, Pasadena Villa, the Middle Path, Village Behavioral Health, UT College of Social Work, and Genoa Healthcare. Now, to access the virtual exhibit hall today, there's a tab at the top of your symposium conferencing page, and you click on the exhibit hall tab and follow the link to be able to access the virtual exhibit hall and take advantage of the opportunities there, whether to become a referral partner or whether to sign in and enter fabulous door prize drawings. Who wouldn't want to have a new big screen TV or a rocking chair for their man cave or their she shed, whatever you want to call it? Who wouldn't want to have a nice nifty grill for the back deck? Fantastic door prizes and offerings from our supporters. And so thank them for supporting the event by entering the virtual exhibit hall and enjoying their offerings. That exhibit hall, by the way, is going to be available to you through December 1st. So you've got lots of time to enter it, and you have the ability to take advantage of the generous breaks that we have built into the calendar today and tomorrow, with 30-minute breaks between sessions and 1 hour break at lunchtime as well to be able to visit the exhibit hall. So about today, the event is accredited, of course, and so we have to tell you how we're going to know that you were there so we can prove to the accreditors that you were there. So you're participating in this event via Zoom on this platform, and Zoom will record your screen name and how long you actually attend each session. So that's how we know you're there. But there's a problem too. If you've got a cute or funny Zoom screen name like Fuzzy Bunny, MD, well, we won't know who you are. So Cliff Tennyson, you need to make sure your screen name says Cliff Tennyson, MD. Or email us at info@MHAET and tell us, hey, Fuzzy Bunny MD is really Cliff Tennyson MD. So please make sure you let us know if you've got a screen name that's not got your professional name in it. So please know that certificates will be compiled and emailed to you. So the Knox Area Psychological Association will email certificates directly to psychologists. The College of Nursing will email their certificates to nurses, and the MHA will email certificates to LCSWs and other social workers and licensed professional counselors, LADAC professionals, and other allied health professions. The Graduate School of Medicine will email physicians attending a link, and you can follow the link to download your certificate from the Graduate School of Medicine. Now, disclosures. Neither the MHA or Dr. Tennyson, our Symposium Medical Director for 24 years now, have any disclosures to make. Any speakers with disclosures should have them listed in their slides so you can become aware. And today's speakers that certainly have disclosures they need to make, and you need to see that they're in their slides, would be Roger McIntyre, MD, and Dr. D'Souza as well. Now, I have a little bit of bad news and I have a little bit of good news. The bad news is our keynote speaker unexpectedly had to cancel last week and has to have some emergency surgery. But the good news is Dr. Rakesh Jain has agreed to step up and take that spot for us so we can make sure that the symposium continues as planned. So it's my pleasure to introduce Dr. Jain. And you may recall from last year, if you attended, Dr. Rakesh Jain is actively involved with the planning of Psych Congress, where he's a frequent lecturer. He is a clinical professor of psychiatry at Texas Tech University School of Medicine.
Good morning to everybody, and live from Texas on a Thursday is Rakesh Jain. That was a great introduction. I really do appreciate what you had to share with us. So, hello, my colleagues. As Ben said earlier, my name is Rakesh Jain. I'm a colleague of yours. I am from the University of Texas here as well, along with Texas Tech. And it's such a pleasure to be with you. It really is. And today, yes, Sandra can't be here, and she really is the main show here. I'm just a supporting actor, but I will do my very best to support this conversation. Okay, so today I thought, instead of just focusing on medications, which by the way are shockingly important in helping our patients with mental health challenges, I thought I would kick it up a notch. I would perhaps take it to where maybe contemporary American and global psychiatry ignores the needs of our patients, which is wellness. But you're going, wellness, that's such a fuzzy topic. That's best left to the non-prescribers, maybe to the, I don't know, maybe yoga, maybe somebody else. Why should I be dealing with it? I'm a real professional. Look at all the degrees behind my name. Look at this fancy office I sit in. And I think we may have to confront this monster in ourselves too, which is our profound biases, our own profound biases of looking at mental health as nothing but a collection of mental illness symptoms, and then determining if they are absent, then we are well.
Rakesh.
Yes.
You have slides for us because we aren't seeing your screen.
Okay.
Sorry.
So let's try that. The screen share, I think perhaps jumped away, didn't it?
Yes.
We will fix that. How is that looking now? Are you able to see my?
Awesome. Thank you so much.
Oh, thank you very much. Okay. So we thought that mental wellness cannot be just the absence of mental illness symptoms. It's got to be more. It just has to be more. So I will walk you through the evolution we have had. And Sandra and I are a professional team. We're, of course, also a personal team. We've been married now for 25 years, but we've been working together just a little bit longer than how long we have been married. And I'm very much a dyed-in-the-wool classic traditional psychiatrist. So if I'm talking about wellness deficit disorder, a term we coined perhaps 5 years ago, and it has a huge resonance with our patients, maybe there's something to it. So today what I'll do, and by the way, thank you so much for joining me this early in the morning, but I do think wellness deserves a place at the table. So what I thought we would do this morning is I will present a case to you. You be the judge, you be the jury. I'm just presenting the evidence. And during Q&A, you are welcome to tell me if that resonates with you or it doesn't resonate with you. So we're going to face this monster in American mental health, which is this pandemic. I know that's a loaded word, but it is really a pandemic of wellness deficit disorder. Sandra and I have a number of disclosures, but none of them really apply to this conversation, but I wanted to be fully upfront, as Ben said. We should be, and I am being. We have published multiple books, so we do get royalty checks, but you'll be happy to know. Every single penny we get from the royalty of the books that we have published, we donate to various mental health charities. We have done that from day one, and it is our plan to continue doing that for the rest of our careers. Learning objectives, I would think you'd be very intrigued by the very first one, augmentation strategy. I'm not at all suggesting wellness interventions should replace traditional psychiatry. That I don't think is a logical way to look at it. More as augmentation strategy. But before we accept it, we gotta know the neurobiology of it. As a scientist, as a clinician, I'm not impressed by good ideas. It's my job not to be impressed by good ideas. It's my job to test good ideas to see if it works or not. And in a few minutes, you will get to see over 10 times we have conducted studies to see if this approach of adding wellness actually helps. You will get to see it. And if you do like what you see, we will give you the actual program. Of course, there's never any cost for it for you to use in your own practices. It could be a private practice. It could be a community mental health. It could be a nursing home. It could be hospice. It could be a university health center. All of the places I'm talking about, yes, wellness would be a useful intervention. But I'm so interested. And by the way, let me back up. When Ben invited me to come be part of this, the easiest thing I could have done is just talked about, I don't know, a disease state and a couple of medications and walk away. But what will that do in terms of residual value for the learner, for you? I don't think that much. But today, I intend to be very value driven. I intend to leave with you a large number of resources that you are welcome to access. But you do need to know who I am. So I am a psychiatrist. I'm also a child and adolescent psychiatrist. I have been fellowship trained in 2 different areas, child and adolescent and research psychiatry. I'm in private practice, but I'm also in academia. And this is my 33rd year in psychiatry. I am very active in research, all kinds. I don't think I have a particular, it's only medications, it's only psychotherapy, it's only wellness. I just truly believe it's going to be a combination of all of the above. You can't accuse me of having lost my mind and become radicalized by the wellness movement. I'm, as I said before, very much a dyed-in-the-wool, a traditionalist. That is not that I've let go of our traditions. I just think they are not enough though. That's why non-pharmacological treatment research, I believe, is so critically important. I am one of the co-creators of the Wildfire Wellness Program. You will meet the other person in just a second. I have been the past chair and the co-chair of Psych Congress, as Ben introduced me very kindly. I'm still on the steering committee of Psych Congress, and I am very much leading the charge nationally and internationally on the development of multiple new medications for the treatment of our poor fellow human beings who suffer horribly from psychiatric conditions. I am very committed to never seeing a prescriber, non-prescriber as this relationship. It is more a this relationship. We are different, yet we are equal, and we bring different strengths to the table. I'm very interested in the future of psychotherapy. I'm interested in the future of biological interventions, and I want to meld them in a way that perhaps I didn't do earlier in my career. Sandra, who can't be here, as Ben told you, but she sends her very best to all of you. She is as you can see, a therapist. She's also in academia. She's also in private practice, a very impressive educator, way better than I'll ever be. You can see how much she's done and what a diverse area of biological psychiatry, psychotherapy, and she's also the writer of multiple books on wellness and wellness interventions. She's quite published. In fact, she's working on 2 manuscripts right now looking at mental health wellness interventions, even in patients with rheumatoid arthritis. And she has now started a study. I'm not part of it. She's leading a study in the Texas Nursing Association. They have a division of impaired nurses, nurses with substance abuse challenges, nurses with mental health challenges, where besides many other interventions, she's now studying if applying wellness, self-directed wellness program could actually improve their short and long-term outcomes. I cannot tell you how important that is. As you know, American nurses, particularly American Caucasian white nurses, are probably the number 1, number 2 highest risk of suicides compared to people in the community. Depending on the study, an American white nurse has about a 200 to 300% greater risk of completed suicides as compared to if she was never a nurse. That's true for physicians too, but it's particularly problematic for nurses. I know we often think it's lawyers, but while their numbers are high, the percentage elevation in nursing is astonishing. You should check out Sandra's work. She has done a lot of work. And in fact, much of what I'm going to present today is her and my collaborative work together. So yeah, we've been partners for a long time. Much of the research you will see today really is me representing our collective work for you. Okay, so there we go, partnership. There's a diverse group of folks online today. You represent different kinds of thought and different experiences, different mind frame. It doesn't matter. It doesn't matter. What matters is, can we work together and learn the best from each other? So here we go. I have considerable time with you. I have 55 minutes to present the data. And yeah, we'll have time for Q&A. So looking forward to it. I'll also give you my email address. So afterwards, if you're interested in reaching out to me with questions, or you want resources, or you have thoughts, not only do I invite you to write to us, you have my guarantee. You will get a response. You'll get a response. So let's go back to, if you will, the last 40 years of contemporary psychiatry, which has been very medication driven. How well has that worked out? So you're in East Tennessee. I'm in Central Texas. We're separated by several hundred miles. But this tragedy, folks, we share together. Our antidepressants, can I be truthful with you? You already know it, are not that good. They're not. Can we just stop making stuff up? So when you go to the NIMH website, when it comes to major depression, it says it's a highly treatable disorder. Well, if it is so highly treatable, why are so many of my patients still struggling a lot? Why are your and my practices filled with repeat business? Is that what you would see in an orthopedic office? Would you? If you were, I don't know, a joint replacement orthopedist, which, by the way, my family has had a couple recently, so I know how that goes. You come in, you get an evaluation, you get scheduled for surgery, you get discharged in 1 to 2 days, you have a follow-up in 7 days, a follow-up in 15 days, and they never wanna see you again because there's no need for it. Are we doing that in psychiatry? No. Why aren't we doing it? It's because our meds, I think we have overbought into the concept our medications are that effective. As you can see from starting, not only they're not that effective, they're not even 50% effective. It actually keeps dropping every time a patient has failed 2 or 3 or 4. Time to stop lying to ourselves and making stuff up. Our meds are good. They're not that effective. That's why we need to keep developing it. And they're not only problematic in terms of effect, side effects. Do you have friends and family members who have taken psychiatric medications, folks? I have. Have you seen side effects? Not in your patients, that's for sure. In your family members, in your friends, maybe even in yourselves. I have. And they can be really considerably challenging. So it's a combination of, if we just rely on medications, we cannot dig ourselves out of this hole of American mental health. And by the way, global mental health, a deep pit we have fallen into. This is our sixth year of rising suicides. It's a real challenge. American longevity, the length, the lifespan of an American since we gained independence, which was centuries ago, started falling last year. What's getting us really are mental health problems and addiction problems. So we want to medicate ourselves out of this? Well, it's not working out. It's not working out. Our relapse rates are high. Our recurrence rates are terrible. Because what we do typically is when a patient does achieve remission, what do? Continue your medications. Good advice, sir. Madam, great advice. What more do you want me to do? Nothing. Keep taking your medications. And by the way, make sure you go to therapy, okay? All right. See ya. Call me. I'll refill your medications. This is what's happening. We're seeing 50% to 90% recurrence of depression. What is missing? There's a lot of stuff missing, and what I'm proposing to you, one of them might well be we are not helping our patients learn the art. It's a real art, the art of wellness. We're not doing that. I was talking to someone earlier today, and she shared with me this morning she woke up and she started filling out her gratitude journal. It was so obvious that was important to her because it should be. It's a real reminder of a high quality wellness intervention. Do we actually teach our patients to do that? Guide our patients to do that, motivate our patients to do that? I know you're thinking, good God, this guy's really left the world of psychiatry and moved on to this woo-woo area of, I don't know where he's gone. And I'm going to push back if you believe that. I have not left psychiatry. I am a very embedded in psychiatry clinician. I, however, am willing to criticize it because it deserves criticism. for being too focused on just one aspect, especially when that one aspect has not worked out very well. But there is hope, and there it is. There it is. So these are the guidelines from this year. These are the Florida guidelines for the treatment of depression. I love that level 1, what they're recommending actually is not medications. Good for them. They are saying evidence-based psychotherapy, CBT, IPT, BA, behavioral activation for mild, and many patients, many patients are mildly depressed. And if you do add medications, never ignore therapy. If you don't get effect from medications, combinations, so all of that is really good. And then you got level 4, you got obviously level 3, level 4, all is good, all is good. But I want you to look at the blue box. Check this out. This is 2020. This is why protesting status quo is actually a good thing. The way I'm protesting it right now. I know I don't look like a radical because I'm not. But how long will I sit in this house that is on fire and say, I don't smell smoke? And if I don't do it close to 60, and I'll retire, I don't know when, God, I hope in my 90s, what have I done other than maybe added to the problems, right? So I'm protesting. I'm saying there's a wellness deficit, and psychiatry is for the most part asleep at the wheel. But look, this gives me great hope. This came out just in October of 2020. This is what it says, the integration of multimodality treatment. Now, hear me closely. With emphasis on positive mental health, resiliency, and human function, invite the need for evidence-based psychosocial treatments combined with pharmacotherapy. Did you hear me? I hope you did. This is where we need to be. This is a call for us to do the right thing. But before we go there, I need tools. This is just words. These are just slogans. And slogans matter. Slogans matter. But I do need direct practical advice, and I want it backed up with science. So for the next several minutes, I'm going to make a case as strong as I know how to for you and I to adopt wellness model as part of what we do. So yes, we do need another augmentation strategy. I want to hear from you if you think I'm wrong, because I am happy to be wrong, but you will have to back up. If you believe I'm wrong, you're going to have to back it up with why you think I'm wrong. And perhaps the big pushback, number one pushback I had, and perhaps you have, I don't have the time. So I'm going to show you a way to do it where your time is not wasted. It might actually be saved. Okay? So let's summarize the fact that data has shown us medications are not enough. There is a pandemic. There really is, folks. So right now, about 0.25% of America right now is acutely and actively infected with COVID. About 3 to 4% of the American population is in the process of recovery. Okay. Hear me, about 16% of America right now is suffering from depression. Am I using the word pandemic excessively? Good, I hope so. I hope it sticks with us. When we say pandemic of mental health challenges and wellness deficit, I'm willing to back it up. It is a pandemic. And it's sadly, there's no vaccine for it. It's not going anywhere. It's actually worsening. And psychiatry is kind of, yeah, what's the next augmentation strategy? Oh, what else you got for me? Another medication? Oh, good. What other medicines can I combine? Well, do all of that. But we are looking the other way. So let's look at this. What is this positive psychiatry? What are these wellness interventions? And now I'm going to pick up pace. I hope you will allow me to do that, because now I just want to present evidence to you. So since 1948, so it's been a while. It's just that we weren't listening. There's been a working definition of what health is. It's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Whoa, 1948. You know when this was, right? Right after World War II. Even after that, when we had such a task to rebuild the world, we were focused on wellness. Yes, we were. Why? Because it's so valuable. We just forgot. So does a wellness deficit disorder really exist? Or is this guy from Central Texas really, I don't know what he's smoking in Austin, but he's off his rocker. He's keeping Austin weird. Maybe you're thinking, well, okay, evidence. Maybe I'm not keeping it so weird. So you do know in DSM-5, there's no diagnostic condition called wellness deficit disorder. But is it necessary for it to be there? I think it is. So this is what we did. Me and Sandra decided to take a temperature of America. We took a thermometer and we put it in the mouth of America. We created a new scale called the HERO, H-E-R-O, wellness scale. I'll tell you more about it, plus I'll give it to you if you're interested in using it. And then we gave it to 757 individuals completely anonymously. We don't know who they are, from across the nation. They could be from East Tennessee, they could be from East Texas, Eastern California, Eastern New York. I don't know where they're from. I don't want to know. I will know they're from America. And this is what we found, folks. This is what we found. On this particular scale, we found that if you had a mental health problem, your happiness compared to if you didn't was diminished by 24%. Your enthusiasm, that's the E part, was reduced by 22%. Your resilience was decreased by 18%, and your optimism was reduced by 23% if you had a mental health challenge compared to the population. Yeah, there's a wellness deficit disorder in our patients who have a psychiatric illness. It really does exist. This was the world's first demonstration in the population, not in our clinic. I'll show you clinic data in a second, and that's, you better sit down, because the data is really bad in terms of how badly our patients are affected in their wellness area when they have a psychiatric challenge. So this is what I'm proposing to you. You'll have to tell me if you're buying what I'm trying to sell you. I'm trying to sell you this. Wellness deficit disorder really does exist amongst us, and particularly our patients. Therefore, we will have to keep traditional psychiatry in mind, but we're going to have to expand it. And that expansion requires an adoption of positive psychiatry. Now, what is positive psychiatry? So it's actually been worked at. It's actually been worked at. So positive psychiatry has 4 main components. It doesn't reject traditional psychiatry, but you look not at, is your depression better? You look at also, is your wellness better, well-being? You also look at resilience, optimism, personal mastery. Please don't accuse me of woo-woo, because I'm going to push back real hard if you do so. And the reason why I will do that, as you will see in a minute, is these are evidence-based. The biology, there must be a biology to it. You're about to see it. There's a very strong biology to it. And of course, positive psychiatry has one great advantage. It's also preventive psychiatry. Wow, it's got multiple potential gifts. And if you are someone who enjoys reading, may I encourage you to read this article that Dr. Geste, who, by the way, is the ex-president of the American Psychiatric Association. He's not a fringe player. He's an endowed emeritus professor of psychiatry at University of California in San Diego. This is the real deal. And he is telling us, has been telling us, we are in need of positive psychiatry the way I just defined it for you. If you got the time, read this paper. If you guys do journal clubs in your clinic, in your organization, read this paper. It's not a rejection of traditional psychiatry. It's an expansion of it. So the truth of the matter is wellness appears to fit the bill. It just does. But why does it fit it? Why is it that you like humor? Why do you like people? Why do you like resilience? Why do you like happiness? Why do you like contentment? Why? What's in it for you? So these are the three reasons why we as human beings gravitate to resilience and wellness. First of all, it helps improve our depression and anxiety. And by the way, it reduces our inflammation. And needless to say, improves our wellness. So it's a perfect mind-body intervention. It truly is. Now, hardcore science, because talk is cheap. And here in Texas, we have a wonderful saying, that's a pretty big cowboy hat you're wearing, son. That's a pretty big cowboy hat you got on. How big is your ranch? So you could say that doctor from Central Texas sure can say this is good and that's bad, but what's his data? I mean, he's a talker. So let's go check out my ranch and your ranch. First of all, the neurobiology of positive emotions is as strongly established as the neurobiology of depression. You know where depression lives in the brain, right? We know quite a bit. We know the ventral medial prefrontal cortex is overactive. We know the hippocampus is underactive. We know quite a bit. Guess what? We know that much also about emotions such as happiness, enthusiasm, resilience, optimism. You're about to see some of it. We also know there are very specific areas of the human brain that light up when we are exposed to positive emotions, not just for a moment, but enduringly so. So you guys all have smartphones. Ever find yourself going to your pictures? What do you look at? Car crashes, right? You've taken pictures of every car crash you've gone and you make sure you take it, right? Isn't that what you do? I'm sure you do that, right? No, you don't. What do you look at? So what we do is we have found ways over time as human beings to reminisce. And what are you looking at? Friends, family, grandchildren, children, couplehood. The same way the human brain has the capability, if taught, to activate its own hippocampus, its own amygdala. And the neurobiology of this is actually very, very well understood. We also know the neurochemistry of wellness. Not only is serotonin involved, it's actually not that big a player. That's why you don't end up seeing a lot of people you've treated with antidepressants report, I'm not depressed anymore, but you know what? I'm full of resilience now. You don't hear that much at all because serotonin is not very much involved in wellness. It's actually GABA. It's actually endogenous endocannabinoids. It's actually endogenous opioids. It's a different set of tools we use. That's why the combination of your and my traditional treatments and these wellness interventions actually work so well. And check this out, inflammation. You, by the way, live in Tennessee. I live in Texas. We are in the top 5, body weight wise, the heaviest people the world has ever seen. I'm not saying we are the biggest people in America. We are. We are the heaviest and the most obese Homo sapiens that have ever walked the surface of this earth, ever. Inflammation is a big component of our BMI and our stressful life. And it's so very interesting. We inflame differently based on, yep, our underlying level of happiness, a marker of human mental wellness. Remember they say, you could die of a broken heart? You really can. You really can. We do know depression is a very bad thing for physical health. What we are now beginning to figure out is lack of wellness is as bad for our physical health as the presence of depression is. Here we've got an interferon alpha. You can measure this in the blood. What we see is people who have challenges with low wellness actually have higher levels of inflammation that's measurable in the human blood. And you know what's interesting? Something we cannot do very much right now, touch, but warm and positive relationships you have with your loved ones, with your friends, with your professional organization, with Ben's organization, the East Tennessee chapter of the mental health organization, those positive relationships actually reduce our inflammation, not just in the moment, but chronically. It's quite extensive. We human beings are simply not designed, we really aren't, to be low levels of wellness. I think we're designed to have high levels of wellness. However, there are many challenges that stop us from getting there. So now I'm going to focus on three things: exercise, mindfulness, and sleep as wellness interventions that everybody, prescriber, non-prescriber in this world, should be using and can use. And I'm going to give you resources. I'm not going to talk the talk. We got to walk the walk a little bit too. So let's do this. First of all, let's just talk about this for a second. Exercise. I exercise 7 days a week. I must love it, right? Heck no, I don't like it. I really don't. I'm not a big exercise lover, but I do it. Why do I do it? Because I am very protective of my mental health. Why am I so protective of my mental health? Well, a couple of reasons. I've had some significant mental health challenges in my 20s and 30s. I almost ended up in my late 20s committed to a psychiatric hospital. I didn't. But I came, based on what my psychiatrist, she later shared with me, she was one evening away. If she had been worried about me for one more day, she was going to commit me. And I would have screamed and yelled, but I would have in the long run thanked her. But things did turn around for me. I have very significant family history of psychiatric illness. I'm the only person in my sibling who hasn't had electric shock treatment yet. And I would like to obviously avoid all mental illness challenges. But what I have found is many things have protected me and helped me thrive. One of them actually is physical exercise, but that's just my experience. Why should you even care about my experience? You shouldn't just care about one person's experience, but you should care about data. You should. Because what else are you going to rely on if not data? And here's the data. It's very clear. People who exercise more have larger hippocampus. So what do you care about hippocampus? Well, here's what it is. Hippocampus, the larger it is, the more resilient you are. The more capable you are with dealing with life's slings and arrows. And exercise, even though you do it in your body, and if you want to, I can explain it to you during Q&A, but even though you do exercise with your human body, has a direct, immediate, and sustained effect, positive impact on hippocampus. Your muscles get bigger, your VO2 goes up, that's all solid, right? But your hippocampus benefits from it. What's the evidence? Even in people who started exercising when they were 76 years old. That's when they started exercising in this study. Still, we're able to demonstrate a clear improvement, not just in MRI measured hippocampal volume, but also their positive affect, their resilience. Don't ignore exercise. Just don't ignore it, either in yourselves or in your patients. And let's turn to mindfulness. I didn't say meditation. You could say it if you prefer it, but I did say mindfulness because there is a little bit of difference. But the difference is relatively small. So mindfulness, which by the way, I will give you resources, obviously free, for you to use with yourself and your patients if you so desire. But the studies are showing something absolutely fascinating. Mindfulness intervention, even as little as 6 weeks, 42 days, as little as 8 weeks, that's very little time, shows changes in the human brain that can be measured on an MRI. But where are the changes? So check it out. It's the anterior cingulate cortex, it's the medial prefrontal cortex, and the amygdala. Now, why should you care? These are the very regions where depression lives and anxiety lives and stress lives. And if mindfulness can affect it positively, are you losing out or are you winning? Yeah. So physical exercise, mindfulness, absolutely. You just tell me how much evidence you want, and I'm happy to provide you with functional data, with imaging data, with blood markers. You just tell me what you want. The evidence is in. Mindfulness is a biologic intervention. Sure, you don't give me a medication, but the effect is biological and psychological and social. It gives you all three. And by the way, let's not forget sleep. Let's not forget sleep. Good sleep and of course, bad sleep, insomnia. Insomnia is very damaging to the human brain. It really is. Any of you nurses? I think many of you are. Either you are practicing as an RN, LVN, or you're practicing as a nurse practitioner. Got it. You may already know this, but WHO almost 20 years ago classified working night shift as a nurse. WHO classified working as a night shift as a nurse as a level B carcinogen. I know you heard me right. Carcinogen. In other words, folks who have to have insomnia because they're working the night shift 3 to 5 nights a week, their risk of inflammation and mood difficulties go up. And there is an association, not necessarily a causation, there's an association with their rates of cancer going up. Not just the kind that have to do with smoking, all kinds of cancer going up. Because insomnia leads to many challenges, mood, energy, all that, but also leads to inflammation. It also leads to, degenerative brain changes over time. So what you're going to do? You're going to prescribe a sleep medicine for me, right? Maybe. How about prescribing sleep hygiene? Oh, nobody listens to me. All they want is a pill. Well, you may be right. You may also be wrong. We too often just prescribe medications. I cannot tell you the number of times I hear patients say, I went to see my primary care or my psychiatrist. I told them I wasn't sleeping well. This is what they told me. You got to sleep better. And here's a prescription. Now, is that really sleep hygiene? It's not. It's not. It's preaching. Preaching is good. Preaching is good. I'm all for preaching. But preaching without direction really is designed to make me, the psychiatrist, feel better, like I've done my job. I've not put my heart into it. So again, I will give you some resources on it. I also want to remind you that wellness interventions are anti-inflammatory. Have you seen the data that patients who have COVID are more likely to become not just short-term, but long-term more depressed and anxious? You've seen that data, haven't you? Yeah, but hold on. That's not what I'm talking about. I'm talking about, have you seen the other data that people who start with depression and start with anxiety are more likely to get COVID? Yep, it's a circular relationship. So if you were someone who didn't quite believe in wellness for yourself and you didn't quite believe in wellness for your patients, this is probably a pretty good time to change your mind. It's a pretty good time. If you're watching the folks who come to your church, to your synagogue, to your Walmart, to your kids' soccer games or whatever, get overtime, be higher and higher BMI, maybe you're seeing it in yourself. Not a bad idea to adopt wellness as a model. In fact, it's a pretty good time to do it. The evidence is really very strong, folks. The three things we just talked about, physical exercise, for example, it's a very interesting anti-inflammatory. It is peripheral. It reduces inflammation in your body, but there's really good evidence. It reduces evidence in the human brain. And yes, the human brain gets inflamed during times of stress, or we have obesity, or we don't sleep well. or we're stressed. This mind-body division really is so faulty that we need to not pay lip service, that mind-body connection is one thing, we should adopt it. We should literally make it our central foundation. We have done so much damage to ourselves and our thinking by calling it mind and body. When I talk about your heart, do you divide it up? Do you kind of say my left atrium and my right ventricle and then divide them up? I want my heart health. Which one do you want, left ventricle or the right atrium? We never do that, do we? We say, I want my heart to be better. So when we talk about people, they don't have a mind, they don't have a body, they have them. These divisions are very dangerous. And that's why physical exercise is one of the ways for us to look at it as a unification. And by the way, you don't need to lose weight. That's the other beautiful thing about physical exercise and the mental health benefits we get. You do not, the evidence is in, there's no need for weight loss in order for you to get the anti-inflammatory effect from these interventions. That's a really good thing. And by the way, this stops the excuse many of us have used. I don't lose weight. Our patients have used that excuse. I don't lose weight. Why should I exercise? Well, sir, madam, this is why we need to get to it. And by the way, mindfulness is not just something that helps us deal with stress. It also appears to act as a vaccine. A vaccine for what? Vaccine for stress and inflammation. So people who practice mindfulness, and by the way, when you talked earlier, Amanda, about you filling that gratitude journal out, I don't know if you realize this, you gave yourself an anti-inflammatory shot this morning. I hope you can see my thumbs up. Good job. You got lots of benefit, but one of the benefits you got is today your inflammation will be lower. And the next time stress comes, like a speaker like me just screws up his Zoom presentation or something, your inflammatory levels will rise much less. And by the way, helping people with sleep, doesn't matter how, will also help, because poor sleep does this, folks, to inflammation. Look at this. I'm bringing you 72 different study meta-analysis. These are really bad inflammatory markers. C-reactive protein, interleukin-6. I hope you're noticing, no matter how far your eyes can see, people who don't sleep well are just terribly inflamed and not well. We will have to take a real responsibility on our shoulders to talk about sleep hygiene. So much talk. Oh my God, is your head spinning? Is your head hurting a little bit? You're like, stop already, dude. Stop. I was kind of worried to begin with. Now you're really increasing my worry. Well, I did succeed in my mission then. I wanted to increase the worry. We have been a little too complacent. We keep waiting for the next great hope, some big medication to arrive. That'll be an injectable, or it'll be a super pill, and it'll cost so much, but God, it's gonna fix everybody. That ain't gonna come. It's not gonna come. I know it's not gonna come, not because I'm a pessimist. I'm serving on about 30 advisory boards. I know what's coming in the next 5 to 20 years. That is not coming. It's better than where we are, but this magic cure is not coming. Not in your and my lifetime. So I want to introduce you to something that you may or may not already be familiar with, which is a self-guided, free, I like free, self-guided, I like self-guided. I'm already pretty busy. I don't know if I can take on guiding every single patient. And this is a program we created and we researched called the Wildfire. I'll tell you what WILD stands for. Wildfire Wellness Program. It's a 30-day program. There's also a 90-day version. I think you should think about the 30-day to start with. It's called Kickstart 30. There's a lot of data on it. So let's go for it. This is the history. This is not complete. There's been many more things we've done, but I just wanted to give you a quick snapshot. This wellness program is not just an idea. Maybe not even a good idea. It's an idea we've researched. We want to apply the standards of research where you really want the study to fail. And only if it works do you start believing it, which is a very good approach. It's a very cautious approach to doing things. So this is why it's called WILD, W-I-L-D, because the program is Wellness Interventions for Life's Demands. So if you say, but I don't have panic attacks, I don't have any psychiatric illness, I don't need wellness. Nope. Do you have life's demands? Do you have any life demands on you? Of course you do. Then the wellness program will work for you. I suffer from bipolar disorder. Well, okay. Do you have any life's demands? You do, don't you? Okay, this is for you. And it's called 5 because it's based in these 5 elements: exercise, mindfulness, sleep. We talked about 3. Because of time, I didn't cover nutrition and social connectedness. Maybe some other time we can do that. And of course, we always make sure it's wrapped in positive psychology. So every single day, people do just 5 minutes of a gratitude exercise or a reminiscing exercise or enthusiasm building exercise, just 5 minutes. We are even doing it with 12-year-olds. This is the workbook. It is on Amazon. Amazon wouldn't let us charge any less than what it is. I think it's about $6 something. And every penny of the royalty, and you have my assurance, every penny of the royalty does get sent back at the end of the year to various mental health charities. And last year we gave a 4-figure checks to 2 different mental health charities, national mental health charities. Okay, so because of time, I won't go into it, but it's a very prescriptive program. It's not a good idea. Like, for example, I'm your patient. Let me play your patient. And you say, you got to exercise, Rakesh. And I'll say, okay. All right, see you later. No, you need to tell me what kind of exercise, how much, and to document it. I am convinced Weight Watchers works, not because they have good ideas, because they have no better ideas than your grandmother gave you at the kitchen table. But what they do is they have monitoring and documentation. And we learned that the hard way very early on to incorporate that into the Kickstart 30 program. So everything you're seeing here is documented. Look at mindfulness. We didn't tell them, go to the App Store and find something and start doing it. That is a very poor way to execute behavior modification. So we went into the studio ourselves. Here in Austin, there's a lot of recording studios. We hired one for 2 days. We said to the guy, you only have one job, which is just to record us doing mindfulness meditation. And me and Sandra then recorded multiple mindful meditations, put it on a CD, but who does CD now? We put it up on a website. It's free, of course, MP3. And you can go there, wildfiremeditations.com, and your patients can go there, download them. And this is all we ask for. This is all we ask for, about 10 minutes a day. We're not asking for 5 hours, 3 hours. And by the way, it's not anti-religion at all. It's not pro-religion at all. At all. It's mindfulness. It's mindfulness. I have had some pushback from certain folks who say, you are being anti-Islam, or you're being anti-Hindu or anti-Christianity. No, no, no. It has nothing to do with it. Certainly keep practicing it. This is just about the art of mindfulness. Sleep, we give people a menu. We literally do a menu of 6 sleep hygiene, and they got to pick 4. Just for 30 days. Social connectedness, which has become even more important. And then nutrition, we're asking people to log. We do tell them which kind of diet they might want to follow. It's called the MIND diet, Mediterranean and DASH combined. And we tell them exactly what it looks like. And it can be scored. See, document, 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 document. So what's the evidence? So all good, lots of talk. Okay, you know, the program sounds pretty good. No different than what I already knew, and no different than what I learned in 6th grade. My health teacher told me, but what's the data? So here we go. This is one of our earliest studies. 82 people, all of them had an Axis 1 diagnosis. I know Axis 1 has gone away, but I still like the Axis 1 aspect. All of them, most of them more than one. Nearly all of them, 95% are taking a psychiatric psychotropic medication too. Okay, check this out. This is the improvement we got after 30 days. And remember, we never saw them in the 30 days they were doing the program. We told them what the program was, educated them, and then let them do the program on their own. And that program, there's a lot of self-monitoring. Did everybody do every day? No one did every day. No one. We got between 9 out of 30 days, depending on the intervention, to 17 out of 30 days. But that was enough. We got 30% improvement. Remember who they are. These are DSM diagnosed conditions. 30% improvement in happiness, 51% in enthusiasm, 45% improvement in optimism, and 63% improvement in resilience. Total cost, 0. Side effects, I don't have any side effects to report to you. Could it work with medication? 95% of them were on psychotropic medications. You still think wellness is a bad idea? Like you're saying, but what am I going to do with wellness improvement? I want to see if it improved my disorder I'm treating. Not to worry. I'm a researcher. I like using markers. I'm right with you. PHQ-9 improved by 43%. Pittsburgh Sleep Quality Index, which is what the FDA uses to approve medications. We use that same scale, improved by 29%. Anxiety improved by 40%. So you can get both. You can get improvement in disease. Let me go back. You can get improvement in wellness. You can get both of those with a program that should time-wise take you 20 minutes to 30 minutes to explain once. And then, no. And patients will never be perfect. You want to encourage them to do more and more, knowing fully well no one, not you, not me, not our patients, are going to do every single day. But that's all good. How do we actually implement it? How do we actually implement it? I mean, that's all good. I don't think anybody's going to fight me on the goodness of that. But you are going to say, I'm too busy. My patients are too sick, and you are right on all of those. Well, suggestions for you. First of all, measure. It's much easier if you measure. Okay, has anybody here had hypertension? Me, I just took my blood pressure medications before I started. You know how I found out I had hypertension? My clinician told me. How did she find out? She measured it. How she tell me when to increase or decrease or change my medication? She measured it. Okay, if she just told me, I think you got hypertension. I just think you do. I wouldn't have bought it. And then she would have said to me a month later, I think your hypertension is no better. I'm going to add another medication. I would have went, no way. But I do think measurement matters. Now, we haven't had good scales to measure wellness. So we created our own. It's now published. It's now published. It's in the public domain. You're welcome to go get it. Its validity and reliability of it was actually very good, over 90%. So the name of the scale is HERO. You remember, don't you, what HERO stands for? HERO Wellness Scale, 0 to 50. You guys may want to take a HERO Wellness Scale yourself. You guys may want to do that. And if you're anything less than 25, you really, really, really need to think about what's going on. And if you're at 40 or higher, congratulations, you're thriving. But if you're 25 or lower, something isn't right in paradise. We gotta, or more importantly, you want to sit down and figure out what the deficits are and how you can best address them. So yes, you can use numbers matter. Really, they do matter. And helping patients understand where they are, give them intervention, remeasure it, and then show them you improve 20%. You improve 20% in 2 weeks or 4 weeks. Good job. But what can we do to make it 40%? What can we do together? Or what can you do with my guidance and my encouragement and my coaching? Tracking really matters. Remember we talked about that a second ago. Good ideas are a dime a dozen. They really are. You open up, I don't know, this morning while I was waking up, I, of course, was checking the latest COVID numbers. And then, of course, Google decided, thank you, Google. It loves to send me every morning things it thinks I'm interested in. So you know what it sent me? It sent me some cool stuff on specific exercises I'm interested in. It sent me some stuff on travel, some stuff. Oh, all good, all good. And already, oh, I'm going to try that exercise today. But you know what? Unless I track it, I'm going to forget it in 2 days. Because I saw that cool stuff a month ago. I have no memory of it whatsoever. But watch this. We created a tracking form that is in the workbook. You can also come and download it for yourself. But we created it just to create accountability. Accountability to self and to your partner. In that case, you, by the patient, is a make or break mechanism. Because without it, all you've done is lectured me. That's all you've done. That's why Weight Watchers works. That's why Jenny Craig works. That's why behavior modification works, because there's accountability and there's tracking. When that's missing, it ain't gonna work. And I will appreciate this. And I want to acknowledge this. This is not like, oh, a light switch got turned on and now it's all magic. It's all going to be easy. No, it's not. There are barriers. Let me show you some barriers. And 1, 2, 3, 4, 5 are the ones we have encountered. My participation isn't perfect. I forgot 3 out of the last 7 days. I'm going to stop. I want to start all over again. I'm hurting too much. Do I have to? I can't stop my Netflix. I like my Netflix. Oh, I use my phone to sleep. I just have to have it. Oh, I do my emails at night. Nope. That's my one thing. You want to take that away? I don't have time to meditate. You don't have got 3 kids? You know those kids are out of school? I'm homeschooling them. Do you know I have to cook every single night? Do you know all that? You want me to log food, huh? Really? Really? That's what you want me to do. And here are some of the solutions you can offer them, because those are legitimate points they're bringing up. Okay, semi-legitimate. First of all, perfection is not the goal we ever had. Improvement was the goal. Do your best. There's 5, you got 5 opportunities per day. And every single day is a new clock starting. Let's see how many you hit. And the tracking form will tell us, oh, pain stops you? No problem. No problem. I understand. I totally understand. Could you do 10 minutes 3 times a day? Oh, you can't do that. That's okay. Can you do 5 minutes 2 times a day? Let's start with that. Let's start with that. Let's start with where you are. We will build up. Negotiation is perfectly legitimate. I can't do it. Okay. Can we start with maybe 2 days out of the week? Just 2. Then we will talk about it in a month. That is perfectly okay. Like yesterday, I saw a patient. He's in Oregon, by the way. But he's the son of a friend of mine, and I really need to see him. He's not a young man. He's a young man, sorry. He's 37 years old. He's using cannabis, now that he trusts me, once every 2 hours. He's using cannabis until he feels it, quote unquote, every 2 hours while he's awake. He said, I know you're going to tell me to stop my cannabis use completely, but you know, I've tried every medication there is. It just doesn't work. I actually told him, I forbid you from stopping it. He loved that, by the way. I said, I don't want you to stop it because I kind of know he's tried that. It's not going to work. He's too anxious. He's too worked up. He's lost his relationship. He's got a restraining order against him. There's a lot of challenges, but this is what I negotiated with him. I said, until I talk to you next, which is in a week, I want you to reduce your cannabis the smallest amount you can that you would not notice. What would that be? And we came up with a number, 25%. I said, I forbid you, jokingly, I told him, I forbid you from decreasing your cannabis use by 26%. Even if you don't want to, I want you to make sure it's at least 75% of your regular. Oh, he loved it. But it did something more. What it's going to do is going to make sure I get to my goal, which is, for in his case, he absolutely needs to come off the cannabis. It's severely damaging everything he's trying to do. But I have to do it slowly. Same way I can negotiate on sleep hygiene, mindfulness. People do say I don't have 10 minutes, but how much are you buying they don't have 10 minutes? And this is what I ask them. How badly do you want me to buy that you don't have 10 minutes? You're trying very hard to sell me on that. And I say 10 minutes, and you could also do this. So I said, do you go to the grocery store? I do. Okay, how about this? Don't meditate while you're driving, that'd be terrible. But when you get to the grocery store parking lot, why not for 10 minutes, put on your headphones and then just practice mindfulness. You don't have to be sitting in a lotus position. Now, that sounds silly, and then patients say, that's silly. I think I can find time. I think I can do it another way. I'm like, okay, I'm leaving it up to you. But you have 10 minutes. You actually have way more than that, but you definitely have 10 minutes. And this logging, it's magical when people log and they realize what they're eating, how much they're eating, how often they're eating. We have seen routinely improvements in weight and their feelings about their weight and the quality of the nutrition they're putting into their body. Routinely, we have seen that because people want higher scores on the mind diet. So perfection is not our goal, folks. That's not what we're aiming for. What we're aiming for is improvement. And I've got 2 more minutes, and I think I can cover the rest of it. Resources matter. So remember I told you that we recorded 1, 2, 3, 4, 5, 6, 7, 8, 9 mindfulness tracks. They're all yours. The website is where you can go get it. Also, on each of these 5 Hero Wellness, we have patient-friendly booklets, completely free. They're pretty nice, actually. I believe they are. You go check it out. You can download it and email it to patients, print it. I don't recommend that, but you're welcome to. But I think emailing it may be best. Because if you're trying to motivate someone to exercise more, why don't we actually show them evidence in a patient-friendly way why it works? Why am I recommending? And the same is true for everything, for mindfulness, for physical exercise, for nutrition. Do go to this website and check it out, okay? And that's the website, Jain Texas Info. If you have questions for us, remember I said we will leave you with our email address. There's our email address, Dr. Jain at wildfirewellness.com. I mean it. If you write to us, you will get a response back. Experience, and we don't have time today, but if we did, if I hadn't talked so darn much, we would have together practiced meditation for about 5 or 6 minutes. I've done this in a number of settings. I have done it with my students. I also did it with a group of psychiatrists in, where was I? Costa Rica. Costa Rica, about 90 psychiatrists. And it was the most fantastic experience. Just because we so often live in the future and in the past, having just 5 or 6 minutes of just us is a rarity that we engage in, even though it's available to all of us. So we won't practice it today, other than to remind you. Let me go back. See the top one, number one, that's 6 minutes, 45 seconds. It's called a 5-minute breathing space. Try that out today. Just try it out today. And if you like it, dislike it, whatever, just write to us. Or I know you guys have your chat groups, etc. You can maybe share experiences. Some of the best ways to teach patients about wellness is to improve our own. Okay, so today, because of time, we won't cover that. And with that, I think I hit it on the nail. It's 8:46 a.m. I want to thank you for your kind attention, dear colleagues. And now let's turn to Q&A. Thank you.
Well, thank you, Dr. Jain. That was fantastic, as expected. Cliff, did you want to start out with a few questions? I've got a couple lined up as well.
Well, I've seen several on the live chat. So let me start with one. And this is about something that I've experienced too as a psychiatrist over the years. But the psychologist who wrote this is asking about psychiatry in general, not just you, not just me. Why do you think it has taken psychiatry so long to recognize the benefits of these wellness interventions as augmentation therapies? And then she goes on to say she worked at a state psychiatric hospital for over 30 years, where the allied health professionals struggled to provide exactly what you are suggesting, Dr. Jain, but often met resistance or lack of interest from the attending psychiatrist as far as wanting to know the patient's response. And you're talking about measuring and tracking to these interventions and activities. So interesting question, which is exactly on point.
Exactly on point. She is landing one on the chin, and I'm taking it as a psychiatrist. She's got a wicked left hook. I can already tell that, and it's well deserved. You're so right. Psychiatry is new. Psychiatry's birth was really only about 400 years ago. It's a fairly new profession. If you look at the rest of the medicine, it's actually a fairly new profession. And our origins were actually humanistic. So if you look at where psychiatry really was born, it was actually United Kingdom, where the traditional model was when people got ill, you bring them into a hospital called Bedlam. Now, most of us think of Bedlam as locking people up, but that was not the original model. The original model was to remove them from a painful, dangerous situation and create restoration. It didn't work out that way. There were just too many people, so they started locking them up. So psychiatry actually was on the right track to begin with, but we clearly lost our ways. Menninger, now this is coming to America now, 1890, 1900s, 1910, also had the right idea. Wellness-focused treatments. If you guys ever had a chance to go to the Menninger Hospital in beautiful Wichita, Kansas, the wellness was actually the focus of treatment, and the rest was ancillary. But then psychopharmacology arrived, and we got seduced by the shiny new penny, Cliff. I think that's exactly what happened. And we invested too much in one stock, and that stock did go up. We helped a lot of people get out of state hospitals, but we left them as the walking wounded. And we also assumed that psychology was answerable to us, and we were the experts in mental wellness. So it's a heritage issue. Don't give up on psychiatry. There is a true resurgence of wellness from traditionalists like me, My residents and my fellows, who are the future of psychiatry, are completely bought into this for one simple reason. This is the only way to explain human flourishing. So don't give up on psychiatry. We did go off the rails a bit. We are gradually coming back. Just don't give up on us. Keep working with us. We are ready now to incorporate wellness as part of the treatment paradigm.
Here's another one that Ben pointed out to me. One of our other speakers, Dr. Cook, asks, what about social rhythms therapy in bipolar and major depressive disorder?
Yeah.
And then maybe after you address that, someone wants you to remind us again the name of the 30-day program that is being discussed and how they can access this for themselves. But first, Dr. Cook is asking about your thoughts on social rhythm therapy in bipolar major depressive disorder.
Yep. Hey, Dr. Cook, nice to hear from you, a little bit indirectly, but I know you. It's nice to receive that question. Social rhythms therapy is essentially what we talked about today in different terms. Social rhythm of what in bipolar disorder? Social rhythm of energy, of sleep, and social engagement. That's essentially the core foundations of social rhythm. Every intervention I talked about today has now been studied in people with bipolar disorder. The strengths of social rhythm therapy, we should look at it, are considerable. It works very well with pharmacotherapy. The weakness of it is it's not very prescriptive. You have to create a new prescription for every single patient. That's a challenge. If you've got 22 people to see in a day or more, that's a real challenge. That's why the program that we created, we made it a more of a workhorse that could be used in multiple non-conditions, but also conditions. Now, in terms of where they can get the program, Cliff, you can get it for completely free. If you go to the website, we actually have a PDF of the actual workbook, so they can just download it, or they can go to Amazon and get that workbook. It's called Kickstart 30. Kickstart 30, and you type in my name and it pops up. Those would be the two ways you can get it.
And Ben, I think you had pointed to a question about diet to see if Dr. Jain could help the questioner about that.
I've lost that question, Cliff. I'm sorry.
I've got it. Here it is. You ready?
Okay.
Yes,
Dr.
sir.
Jain, you have used comparisons to other diets on the market today. What are your thoughts on how this program relates to the damaging effects of diet culture? And how are prescribers trying to combat this?
Diet culture is in some ways pretty damaging. So the MIND diet, whoever asked that, I don't know if you're quite familiar with the MIND diet, is, even though sadly it's called the MIND diet, it's actually not a diet program. If you get a chance, look at the reference on the slide. And by the way, Ben, I think you are sharing the slides with all the audience, right? They have access to it in PDF format. Ben is shaking his head, so you have it. So all you have to do is check the reference out. Dr. Morris, who sadly has died because of cancer, but she's the one who created it. It's not a diet program. What it is healthy eating program. So if you want to keep eating, I don't know, fried foods, you can absolutely do that. Okay, it's not a do this, do that. It's more a measure of, there's 15 items. It's more of a measure of, are you engaging more in healthier habits and engaging less in unhealthier habits over the passage of time? It's not a diet, because they don't work, not for mental health, not for a chronic time. And we adopted the MIND diet as our model because they actually have MRI evidence of changes. It's actually not just a good idea with weight loss. It's actually a program not designed for weight loss. It's designed for brain health. with evidence. And I'm a big believer in evidence. So your point, whoever asked that question, is not only very well made, it's very well taken. We walked away from a diet. It just so happens it's called the mind diet, which I think is unfortunate, but it's more a mind diet style eating habit change. Check it out. I think your worries about it being a diet program will fade within 5 minutes after you check it out.
Okay, the next question, Dr. Jain, Jan, excuse me, comes from Deborah Calder, a social worker, and she asked the question about some of the barriers that folks toss up. Could you revisit a little bit how you surpass some of those barriers from really resistant individuals?
Yeah, and by the way, can I point out 3 resistant individuals to you right now? Me, you, Ben,
Yeah,
and you, Cliff.
right.
Okay, so before we call them resistant, let's be careful now. We're all resistant.
Yeah.
So there are no resistant patients. Resistance is a human trait when it comes to change. So we all are resistant. The issue is how resistant are we? So let's talk about the barriers. I think Deborah, I think you said is the question. So Deborah, the most common one I've encountered is this. I know about this, but I can't do it. I can't do it perfectly. And I don't have the time, or I'm too tired to do it. Those are the 4 most common that I get to hear. The time one is the easiest one to talk about, which is to say, I'm not asking for a lot of time. And let's dig into your day and let's come up with, there might be 1 or 2 days out of your week where you genuinely don't have the time. But let's just find the time. Instead of saying, no, you do, we examine the day. Right. And we look for opportunity. That's the first one. I'm too tired comes up very often. And I say 100%. That's why we'll do this. We'll break it into pieces, and I'm not expecting perfection. If you get it 1 day out of the week, you know what? That is success. Next week will be 2 days. It's progress. Cost. It's going to be too expensive. So I ask him, what's the cost I'm asking for? I don't want to join a gym. I've never asked you to join a gym. I don't want to buy no fancy stuff. I'd ask you to do it. I don't have $6. You don't have to. Do you have a computer? Oh yeah, I got this i12 or whatever that's the 12 model mega. I got that. I mean, I got high speed. I mean, I got everything, but I don't want to spend $6. That's okay. You don't have to. Just go. So no matter what the objection is, it's real. I start with that. Your objection is real. And you're no different than me, because I'm also resistant, and so are you. Let's find a way around it. And this has happened a lot, Ben. It often doesn't stick the first month.
Right.
And it's okay. If I don't have the art as a clinician of patience and resilience, how am I going to teach it to my patients?
Right.
So I'm just patient about it. But many, I can't tell you, Ben, how many times. There's a 12-year-old. That's why she's on our mind. We just saw her yesterday. 10 days. 10 days, this young lady has been working this program with her parents. And this is what she said on her own to Sandra. This is Sandra's therapy patient. Dr. Jain, I'm just nicer. I'm like, oh, what's nicer about you? She said, I'm nicer to myself. She's a cutter. I'm nicer to my body. I'm nicer to my mom. I'm nicer to myself. I'm like, all these medications I've given you for, I don't know how many years, they didn't do what a wellness program can do.
Right. Dr. Jain, I need to end this at this time, but I have a comment I want to share from the comment box. If this one attendee could stand and give you a standing ovation, she would. And so count on us to contact you again to get you to participate in our symposium in the near future. Okay?
Ben and Cliff, both, thank you, and thank you to everyone.